So I've been diagnosed with ADHD at 24 out of 24. So ADHD at the highest levels, combined type. Autism at 203 out of 240. So that is, again, a very high level of autism. And PTSD with 9 out of 9, which is all the indicators.
Right, okay. And how did you go about getting that diagnosis? You say it was only earlier this year?
Yes, so it was in February this year. It was actually quite a strange story, and I tell people this because I think, while it is very personal, I think it helps put into context the fact that these things have a real life element. It's not as simple as talking about teenagers who'd like a bit more help with their coursework, who'll get a diagnosis for some extra time. So in January, I had a really, really bad episode of vaginal bleeding that lasted weeks, and I ended up at hospital. I'd had difficulty with periods all my life, but that was beyond. And I ended up at hospital, and we were treating it as an emergency, and we were looking at people who could be a donor for me if I ran out of blood, because we couldn't work out why I was bleeding and wouldn't stop. Eventually, we were looking through lots of different things. Again, all my levels were coming back normal. And we were talking about what on earth can cause this. The closest we got, somebody said anxiety. And we were talking about anxiety, and because I understand that anxiety can impact your hormones, but I thought to that level, that's really extreme. And then I was told that they think it could be ADHD.
Right.
Which has then been made more drastic by anxiety.
Okay.
So I was surprised by that because I had no idea that ADHD could cause something like that. For context, the link is actually dopamine, because ADHD is about having inconsistent and unregulated levels of dopamine in the brain. Dopamine is in charge of many things, including the regulation of sex hormones.
That is fascinating.
Which is fascinating. It's what a bizarre link.
And what a way to find out.
Exactly. So what then happened, which is kind of, I'd say, where my sort of diagnostic pathway gets a little bit more political, you could say. So then, as a 21-year-old, I've been given this information. I've been told, right, you need to contact this lady. She does the diagnosis. Okay, so I do that. Right, so here I am. I've missed some work because I'm bleeding everywhere. I'm sitting there, and then I'm told that my diagnosis, off the back, so we're not sure. We're looking at its possibility. Was £750. Right, so that right off the bat, that was a difficult one. I was luckily in a position where I was actually able to borrow the money off a family member, but that was tricky. So then I went for my appointment. The lady did a full assessment, because she was saying that it's very difficult when you've got high functioning, high performing individuals to pin down one thing. So we did what is sort of regards a full panel of mental health questions. I have never filled out more questionnaires in my life.
Sounds like my worst nightmare.
Yeah, no, it was hundreds of questions. And even if we think about people who have got ADHD and the administrative burden of doing that, and loads of questions I had to ask my family as well. What happens if you don't have a great relationship with your family? So either way, we did the questionnaires. I then came down for my assessment. There's nothing quite as strange as having somebody assess you for neurodivergence. 10 minutes in, we just stopped, and she says, well, I can tell you now you've got ADHD. Now we're just working out how much. And I was like, oh, okay, so that was quite quick. And by the end of the appointment, I found out I had a combination of the three things, which I now refer to as the unholy triad, because I think it's really important that we understand that each of these conditions does not operate in isolation. They all talk to each other.
Okay.
So I'm not somebody with ADHD plus autism plus PTSD. I'm somebody with all three.
Okay. And what was it like getting that diagnosis? Did you have any inkling prior to this year that you might be somebody who falls under that bracket?
So in terms of ADHD, I was an appropriate adult for a year, and a lot of the people I supported had ADHD diagnosed. That acted both to make me think of its possibility and to rule it out, because I was seeing a lot of behaviours that are not things that I do. I should also say, in terms of my diagnosis, one of the biggest factors that's actually in my psychiatric report is that part of the reason I'm anxious is because I'm spending a lot of my time doing something called masking, which is putting up active efforts to try to look as normal as possible.
Right.
So that's both conscious and unconscious, and everybody to an extent masks. You don't behave the way you do at work that you do at home. That would be bizarre. But what we're meaning is that I'm doing it all of the time to a very high level, including when I'm on my own.
So engaging a filter that you might not have
Yes.
otherwise, like you say, little actions and things like that. And you, like you say, is it conscious or unconscious for you?
It's a mix of both. So some things are certainly unconscious, and walking out of that appointment, one of the things I was told is that to improve my overall well-being, I need to start unmasking. And that's an odd thing to hear, because what on earth does that mean?
Right.
What? Think about the process of unmasking. What is that? Am I going to go through like a second puberty of working out who I am? What is going to happen? And for me, so far, and I'm only a little onto my journey, and the more I talk to adults who are further along on this, I'm not sure it's a journey that ever ends. But I'm learning all about some of the things that I do that are conscious. So, for example, even now, I am slowing down my speech in order to be able to be heard.
I was going to ask you, do you
Yes.
feel as though you are masking right now
absolutely.
during this conversation?
Absolutely. I'm conscious of masking in some very noticeable ways. Yeah. But that's not to say that that's not a way that somebody who's neurotypical may also mask on the radio.
Of course. Anyone on the radio would act and talk in a certain way. But we hope, of course, that you feel comfortable enough to be yourself right now. But you mentioned the financial aspect of getting that diagnosis. It must have made you think about others who weren't quite as fortunate as, like you say, to be able to rely on family.
Hugely. There's the financial side of it, and there's also even just the organisational side of it. So, firstly, on the financial side of it, so my diagnosis alone cost me £750. That had to be paid to get the appointment. I've had some time off work. I get told that I need an assessment, and 2 weeks later I'm paying for it. So that's kind of what we're talking. It's not something that you plan for and save for. And I thought, gosh, that's a big ask. It's a big ask of a lot of people.
Yeah.
And there's one aspect particularly of that I think is really important, and that is that had I been diagnosed as a child, I believe I wouldn't have had to pay that.
Yeah.
And I think that raises really important questions around gender as well, because when we think about a lot of my behaviours that are relating to ADHD and autism, so to give an example, when we look at hyperactivity criteria, people often sort of associate it with children that can't sit still, children that are being disruptive, and therefore something is done because they're causing a difficulty. My hyperactivity is in my brain, and that can actually come across in some ways that look really, really high achieving. And it's obviously lovely that I have the ability to do that, but the flip side of it is that as a child, it begs the question, how is somebody with full marks on ADHD never been flagged? And I think there's if we have a look at how many people are diagnosed in childhood that are men, it's something like 80%, at least in the UK, and that is insane, because it does indirectly mean that out of the people that are paying for their treatment, more of them will be women. And we also know that women usually are worse off economically, particularly at a younger age.
Do you think that stems from, say, a stereotypical or a misunderstanding of what ADHD is and how it presents? Like you say, it's not just, can't sit still, hyperactivity. It's the hidden side of it as well. It's what's going on inside here that is really important.
Yeah, so I think that, with all of them, it's that difficulty around, we know they're invisible disabilities. But I think particularly with sort of ADHD and autism and PTSD, it's how invisible are they? And are they invisible in the ways we think they are? So one aspect of my autism, and my ADHD, but it's been put down as autism, that is fascinating, that I think that I didn't know was a thing. So I have hypermobile knees, which means that I stand and my legs are beyond straight.
Right.
And that is over-occurring in the autistic population. And they found a link between collagen in bones, which is kind of why we have muscle tension, and ADHD. It's also why people that are neurodivergent usually, it's hard to tell how old they are if you're neurotypical. So there was a study done that was talking about the levels of collagen in people with autism. And collagen is one of the things that keeps your skin quite elastic. And on average, people that are autistic, if you were to, in a study they had in America, they found if you were to look at them, you'd guess they were younger than they were. And I think even if that's, I think if we think we know a lot about autism, imagine how much we don't know. If that's just the start of the physical ramifications. So I already, previous to my diagnosis, I had a diagnosis of IBS. And at that point, we were kind of thinking about, okay, so is there an allergy? What's kind of triggering this? And again, there's a massive link between ADHD and IBS and hyperactivity. It's hyperactivity in the body. And, to completely go against the view of sort of there's a naughty boy who's making too much noise, and think about, no, it's actually every single part of your being. And I think there is a huge misunderstanding about what these conditions look like. So when I was diagnosed with PTSD, I was really shocked, because to me, PTSD is something that people that have been in Vietnam have, and they carry under tables when there's a helicopter. It's totally different than that. I'm not saying those people don't as well, but there can be a totally different presentation of that. So for me, I experienced things like disassociation, which is where I feel like I'm kind of not really in the room.
Right.
And that's a very odd feeling, and I didn't know that was abnormal. I thought that was part of being alive. And in my diagnostic report, it said traumatic instances around from the age of around 8. So I am never going to have known that wasn't normal. And as well, on the lines of that, there was something I wanted to flag just about diagnostic criteria that I think is beyond both sad and amusing. So around 70% of cases of ADHD occur in where there's a genetic element, so where one parent has it as well. So one of the things in the UK that if you want to get your child tested for ADHD, one of the check boxes is, have you noticed there is something unusual about your child? If you've got ADHD, no, you haven't. I don't have any children, but if I did, I could imagine sort of submitting something to the hospital and saying, I'm concerned because my child's interested in Love Island. Help me, I think they might be neurotypical. And you just... It's completely, I think that's
because how do you define that?
Exactly. And it all goes back to taking what I refer to as a deficit approach. Mm-hmm. So I think the whole standpoint around what we think of to do with mental health in general, particularly these conditions, is how are they different from the norm? Not just how are they different? Mm. And that's the thing, and I think that it's because of that thinking we've ended up in what I like to call the you're screwed and you're super dichotomy. So either you have these conditions, oh my God, this is a big thing. As one person said to me, who will remain nameless, oh my goodness, do you know that if you have these diagnoses, there's a really big risk that your children could have them too? I mean...
How does that factor in?
Firstly, a risk of autism. I recently posted on LinkedIn about this. So Psychology Today, and I have written to speak about this, they use the term a risk of autism. So speaking on my own behalf, there's not a risk of autism. You have a risk of money laundering. You have a possibility of autism. And I think that by understanding that these things can both be really positive in many ways, and also really, really difficult, and that those two things can coexist at the same time, wrap up into a condition, and still present differently from person to person, that's a difficult thing to comprehend, but it's what we need to comprehend. And I think by doing that as a society, by moving into a more person-centred focus, rather than going, this is the list of things, do you have any unusual interests? And my answer to that was no. Do you hold an outstanding achievement award in anti-money laundering? Yes. That's not an unusual interest. That's my job. Okay. And it's all these subjective terms, like unusual. Well, it's not unusual to
Subjective
me.
is the apt word, isn't it?
Hugely. And and one thing I did say to somebody about, so we talk about autism and compulsions to do certain things and stress if you can't do them, and how it's often misdiagnosed as OCD. So I was looking at some of the criteria for autism, and one of the ways it was defined on a particular psychology website and how it might show up. And I was thinking, okay, so it said, is very, very keen on a certain TV programme that's unusual for their age and gets stressed out if they can't watch it at a particular time. Okay, should we replace the word in that sentence with football? So should we talk about people that are very interested in football? So interested, they even support their favourite team, right? They love it. They're really into it. Sometimes they even pay money to go to a different country to watch it in person. Shall I see what happens if I turn the TV off while they're watching that match? That's ridiculous. I think that we have a tendency to over-medicalise things to an extent. To me, if it ain't broke, don't fix it. Mm-hmm. When we're thinking about kind of my my traits around, particularly ADHD, around having a lot of energy. Right. Okay. Is that a bad thing? Is there something wrong with that? And that's where I think that it gets very difficult in the kind of debate around medication, and one of the reasons that I understand that my own parents maybe were very keen on protecting me from any diagnosis, and I do think that the word protect in the era I grew up, because I was in school in 2009, I do think that's a reasonable word to use, because I think that the provision around SEND, so special educational needs and disabilities, now, this is not to offend anybody who's either in it or working in it, it's not great. And then it was really poor. So, even now we're starting to move away from a one-size-fits-all model. One of the things in my report is that if you were to put me in a SEND environment as a child, I would have hated it just as much as I hated the normal. And I think it's that dichotomy again, because it seems to be we only identify and treat people if there's either something clearly wrong, in inverted commas, with them, or there's something difficult about them. And when you're someone like me who doesn't really fall into any of that, it's not something people are going to flag, even though they should. It's much easier to look at me and go, oh, Mitzi, she's quirky. And then not to actually think, hang on, if Mitzi was a boy, what would we call this?
I was going to ask, in terms of, you mentioned about people being difficult, for example. When you think about certain medications and when we talk about treatment of ADHD and autism, do you think about who the treatment is benefiting, for example? And, is say this medication, say this treatment the best thing for the person, or is it for those around? Is it more for those around them? Have you had thoughts along those lines? I think about that a lot of the time. And I would say, I think both because I'm autistic and also because I'm a Quaker, I think a lot about the ethics and the integrity behind things. So I know there was a big debate, sorry to interrupt, around the use of Ritalin, for example, in America.
So I'm not on Ritalin, I'm on Elvance. So Ritalin it's a different amphetamine. They're both amphetamines, but they do very slightly different things. So part of my thinking around it is that I think whenever you're medicating anybody for any condition, including, for example, my dog, he's got a problem with his feet. When we're giving him pain medication, we have to think, is this for him or is this for me?
Yeah.
And I'd even go one step further than that, because I think it's not quite so much of a dichotomy again. So if we imagine that, so it's all great for me because I'm an adult and I can choose to take a medication at will, I can decide that I won't take it, all the rest of it. But if we think about a small child who is behaving in a really difficult way. So while I totally think that ADHD medication should only be for the benefit of that child, and that child absolutely should have rights around understanding what that is and understanding why they've been given it, I think that we also have to recognise that it's more important to keep families able to function. And I think that we could get into a situation, in theory, where you're basically unable to medicate children because we can't demonstrate that it's only for their benefit. Right. And in reality, if we think about who the Elvance benefits, for me, it's majoritively me, but does my partner also like the fact that I'm able to basically regulate my emotions? Yeah, I think he probably does. But that's different for me. For me, it's that I'm a functioning adult who's able to make her own choices.
Yeah. So if you did feel there was a negative effect on you, you could cut
absolutely.
That
And after my diagnosis, I was prescribed Elvance on the same day. And I said to the prescriber, I said, right, so if this doesn't do anything for the bleeding, I reserve the right to say I don't disagree with your diagnosis, but I don't want it. Because that's really what brought it to a head, the whole situation with the bleeding. And I took it and I was thinking, so I don't know if you've seen Fallout.
Yeah, I have, yes.
Yeah, so it's
the
like
series.
The series, yeah. It's like the first time he gets into his suit,
mm-hmm.
and he's trying to work out all these new proportions and how he even walks. So that's not an exaggeration, because being on it has changed how I walk.
Wow. Okay.
So one of the factors around ADHD is around coordination, and I bump into things. I have all kinds of accidents, and I just thought I'm a bit uncoordinated and I'm asthmatic. It's a combination of those two factors that mean I'm not brilliant at sports. I haven't got the spatial awareness, right? Turns out no. And now I take the medication. The first day, I started walking at double speed. And I only worked that out because, so I don't drive because PTSD, I have seizures, so I can't drive.
Okay.
But I was realising that walks that took me 15 minutes now taking me about 8. And I was thinking, this is all very, very strange. Like a horsey, you know, when they, for a race, they feed them and that's me. And I was like, I'm not a horse, am I? And I was kind of thinking to myself, right, so this is weird. And I ended up speaking to the person that prescribed it and said, right, is this a thing? Is this what is going on here?
Yeah.
I'm not complaining, but it's weird.
But I've turned into Dash from The Incredibles.
Exactly,
so,
yeah, I've
what's
become
going
the
on?
Flash.
Yeah.
And it turns out that I'd been spending so much time thinking, left foot, right foot, left foot, right foot, that it was taking me longer to walk, like a toddler. And without those elements, with the dopamine and the right level of regulation, I can just walk. And because I've been putting so much effort into walking for such a long time, I'm really fast.
So is it quieting down the unconscious part of your brain then and giving you more space to just keep one track, if that's how it is?
I'd say I don't know how it is for everybody, but I think for me, because of the joint 3 conditions, it's a little bit more complicated and odd than that. So I give the analogy of, and this is because of my job, it's a great analogy to do. So I like to think about the ADHD, and he's a great CEO, really character-driven firm we've got going up in my brain. It's lovely. They are making so much money up there. Everything's rolling in. Unfortunately, there are piles of paper everywhere. And the executive, he's finding it quite stressful. He's struggling. He's getting ill all the time. This firm is having some problems, not because it can't do it, but because there isn't enough structure in place for it to be able to do it as well as it could. So then the executive, and this is this great play on words because the executive is dysfunctioning, which is, yes, because executive dysfunction is a key part of it. I know, it's very fun. So the executive thinks, right, we need some help in here. So he gets a compliance officer. So compliance officer is the ADHD meds. So in they come, and they're only there 9 to 5 because ADHD meds are 8 hours long. But the compliance officer can help regulate things. The compliance officer isn't saying, no, shut down business, you're gonna do a different thing. They're just helping sort out some of these piles of paper, helping to regulate some of the ideas. So when the CEO's jumping on the table and saying, we need to do this, the compliance officer goes, 1 minute, please. Is this a good idea? And they talk it through. And it's not that they won't do it. It's not that the CEO doesn't have ideas anymore. It's not that the CEO has been sort of put into some kind of medically induced coma. It's just that the compliance officer is able to help a little bit. And while the compliance officer is in, they can also do things like policies and procedures. So making structures in the brain, learning methods that work. So that then when the compliance officer goes home, when the meds run out at the end of the day, those structures remain.
It's fascinating hearing you speak, Mitzi, and the way you put things into analogies is really fascinating. So thank you for sharing your experience with this. I want to move on a bit into the plans on the Isle of Man now, because we've heard this week about plans to create a new NHS diagnosis pathway for neurodivergent people on the Isle of Man, and Tynwald has passed plans to create a diagnostic centre for those with ADHD and autism by the 1st of April 2027. What do you make of those plans?
Firstly, good. Secondly, doesn't help me much, does it? So, on the good front, I think that it's excellent that we are actually putting things in place. And that we're working out ways that we can do that where we aren't going to be forced to pay for a diagnosis. It's effectively essential. I say this, and I really don't think it's an exaggeration. If I hadn't have had an ADHD diagnosis and then medication, and have been able to afford both of those things, I could quite possibly be dead by now, because they may not have been able to find a blood donor, and I could still be bleeding out, and that could be the end of me. And I think that, so to argue that my ADHD medication is somehow optional, I'd say is medically incoherent. And also, I dare say that that's not something you would get away with saying for any other disability.
No.
And I think, unfortunately, that part of the reason that's been able to happen for so long is because a lot of the people that we think of as having ADHD are people that we don't like as a society. And it's a horrible thing to say, but I think that's how we feel. by having a diagnostic pathway, we have to realise that it goes one step further than that. It's because, imagine it's 2027 now, and this
it's
happens to me
societal.
now.
Yeah.
Would I go, if the bleeding hadn't have happened, would I go, oh, I think I've got ADHD, I need to go on this NHS list? No. I also worry, and I don't mean this in a derogatory way at all, I also worry about how they're going to be diagnosing it. I worry about, because when we have a look at the UK and some of the effectively unregistered practitioners that are sprung up that are doing ADHD diagnoses, I want to understand here that as part of that provision, that the people that are doing it are up to date and up to standard.
You'd like to see like a register.
An actual register,
yeah.
an actual understanding of who it is that's doing it, why they're qualified to do it, and why it isn't going to become let's stick that down your throat, see if that works. Because that is not the idea, and that is harmful both people without ADHD and people with ADHD.
Yeah.
And as well, I think around PTSD, and that's one obviously that isn't really encompassed under neurodivergence. I know there's a little bit of debate around whether it is when it's sort of in childhood, because PTSD you can have as an adult, which is post-21, or as a child, which is pre-21. So I've got a diagnosis of both. And I understand that the pre-21 one, a lot of people argue, is a type of neurodivergence because it's impacted how your brain is developed. So, and I think we need to fundamentally shift what we're looking at when we're talking about PTSD. So we need to, for example, part of the criteria is you can have something called level 5 military PTSD, which is part of what I have, except I've never been in the military. So right there, you've got a real issue with how you're describing it. And I think that when we are, it's great to have these pathways, and it's super. Firstly, I've already had to pay. I fall into that gap. Are they going to try and re-diagnose me in order for me to get a medication on the NHS? How will that work? Will they then say, oh, but you're doing pretty well, so you're at the bottom of the list. You can wait 5 more years. Okay, right, fine. So does that mean that the diagnostic pathway opens to people like me in 2032? And we're getting closer and closer to seeing that this could be brilliant. I don't deny it. I don't want to poo-poo any attempts to do great things. But it needs input from neurodiverse people. It is not enough to go, like, I have some brilliant conversations with doctors where they try to explain to me what neurodivergence is. And I'm thinking, okay, so you've had 20 minutes somewhere in a medical lecture where they've put it aside now, oh yeah, also some people have autism. And you're trying to tell me this is how it presents. And then when I say, but this is how it presents for me, and they go, oh, yeah, okay. Yeah. And that's when we need input from neurodiverse people. And I think that when we're really thinking about lived experience, which is what I'm really trying to share, because I think I'm in a unique position where I've got 3 diagnoses that all are quite serious and all impact each other and me in different ways, which is why I've been doing quite a lot of work with different research universities to talk about how these traits actually show up. So I noticed that the 2027 date is roughly also when the DSM-6 is due to be out. So all of these disorders are diagnosed.
Just explain to us what the DSM-6 is.
So at the moment we have a DSM-5. I joke that it's like the Elder Scrolls 5. We're going to get the DSM-6 before we get the Elder Scrolls 6. So the DSM is all about, it's a diagnostic manual that clinicians have to use to make these diagnoses. So as far as I'm aware, pretty much all mental health disorders are in there. It's the American version that we use here.
Okay.
There is a British version, but my understanding is that we do use the American one, and that is how I've been diagnosed. I have many opinions across 2 of them, but I think both of them have their merits and their demerits. So every now and again, so the DSM-5 was in 2013. They explain the criteria they're going for in a little bit more detail. It's not about that we've invented any new disorders. It's not about, despite what reform may have you believe, that suddenly everybody has caught ADHD from the screens. It's that we're now looking at people that we never before would have looked at. And also, interestingly, we're moving more towards looking at ADHD and autism first. So where previously people have been diagnosed with stuff like bipolar, based on, kind of like a 20-minute interview.
Yeah.
We're now looking at, actually, no, could it be other things? And I think that when we're sort of thinking about that in terms of a new DSM, I mean, I don't wish to speculate on what will be in it, but I imagine it will broaden out who falls under lived experience and will give better examples that are more precise. So at the moment, one of the examples around autism and language is that there will be a language development delay whereby children speak differently to other children. Okay, so if we're thinking about how that presents in me, that's not about me not being able to talk. And I think that, I hope and I believe that the DSM-6 will broaden that out.
Okay.
And I think that's therefore actually a relatively good date to be picking, because what you don't want to do is set it up on DSM-5 and 6 months later be out of date.
You mentioned about talking, communication, and hearing lived experiences from neurodivergent people. I wonder, have you spoken yourself with the health minister and other people?
So I've reached out.
Yeah.
I've been talking to David Ashford,
Yeah.
to Jane Farragher, to other people about my own lived experience and how I think that experience could help both people that are trying to make the rules and also people that are thinking about, I've got something going on, but I don't know what it is.
Yeah.
Or also for their children. If we think about the fact that you can't flag something as odd, if we can have me talking about kind of, this is what I've got and this is how it affects me, then we can broaden who we understand as having ADHD rather than immediately going down the route of the most obvious people. And absolutely they should be diagnosed. Absolutely that has a place and they do need assistance. But not everybody who has ADHD is upside down.
Yeah. It's an interesting time on the Isle of Man. It's fascinating to speak to you. I hope you don't mind me just letting you speak,
No,
because
definitely.
Questions I could ask a million, but it's more important, I think, to let you speak and hear what you have to say about this. And I think just kind of looking forward, what would you like to see happen on the Isle of Man over the next few months in the process of this strategy and the diagnosis pathway being put together?
So I think that having some kind of input from the neurodiverse is key. I think with any condition, but particularly invisible in inverted commas disabilities, we need to understand from people who actually know what these things are like.
Mm-hmm.
So, for example, until I had my first post-traumatic seizure, I didn't know they were a thing. I was lying there with my body freezing up and one hand stopping working, and I was thinking, what on earth is this? And I already had a PTSD diagnosis, and I still didn't know what it was. And in terms of the lived experience, I think that's why we need people's input. We need people to be able to share, right, it's all well and good saying this is a criteria, but how does that actually look? Yes, it's like mark schemes for kind of English essays where they say, the candidate shows a clear and consistent approach to the question. What does that mean? What does that actually look like? Who is that?
Mm-hmm.
And what is the range of different experiences that can be? Because my lived experience is only one of millions. For each neurodivergent person, there's a different lived experience of neurodivergence. And I think that we need to take some real action to reach out to these people and to get them in the ways that they want to do it. I was even thinking with one MHK I spoke to, when the initial thing was, when I reached out, it was, can we arrange a call? And I thought, yes, we can. However, if I was a different neurodivergent person, I would hide.
Yeah.
And that would be the end of the conversation. You'd never hear from me again. So I think that we need to think about the way we're approaching these things. We need to think about all accessibility and accommodations in all its forms, and how actually a lot of those accommodations will be good for everybody. So if we think about overhead lighting, we think about people with autism as finding that really quite stressful and tiring. Who likes being in the supermarket? Who likes overhead lighting? And who wouldn't be happier if we could turn it off? And that's where I think it needs to go. I think we need to really take people's lived experience and run with it. Just because you're a doctor doesn't mean you have all the information about how it is to live it, just as how you are as a neurodivergent person. I'm not going to start opening a diagnostic clinic because I don't know about everybody's experiences, but I do know about mine. And I think that's where we need to be.
I think that leaves us at a nice point. Is there anything else you'd like to mention at all?
Just that if you're looking at diagnosis, or if you've got a family member, friend, child who's looking at one, or that you think might be looking at one, don't think it's the end of the world. It's hard, and there are a lot of difficulties with it. For example, this morning I got confused about whether or not I brushed my teeth and ended up brushing them 4 times. And then my gums started bleeding. And that's just one example of a normal morning on medication as well. I think that we need to move past it and see that people can be brilliant. Neurodivergent people are excellent. And we need to appreciate that while also appreciating that they have many ways in which they need help. But don't help them by walking up to them and try and do things for them. Ask them how they'd like help. They do know. Ask. And that is my thing. I think if anybody remembers anything from this, it's that neurodivergent people absolutely have agency, and we absolutely should have input into everything that's happening here. And also when it gets going, if it gets going, and I really hope it does, you need to then get the people back to say, has this worked? What are the outcomes of this? Did it work for you? Do you like the medication? Do you wish this had never happened? And I think that is how we'll build a system that is actually functional with good, solid outcomes, not feeding people pills because you're so upset because I'm making noises.
Thank you for making it to the end of the Manx Radio Newscast. You are obviously someone with exquisite taste. May I politely suggest you might want to subscribe to this and a wide range of Manx Radio podcasts at your favourite podcast provider so our best bits will magically appear on your smartphone. Thank you.